Thank you. Hi, everyone. My name is Richa Gupta. I'm an advanced heart failure and transplant cardiologist at MedStar Washington Hospital Center. And I'm excited to just present a little bit of kind of real world application and just sort of, what the logistics are that go into kind of creating a Barostim program. So I'm going to get into kind of our referral pathways, who are the patients that we evaluate, and some patient selection algorithms. This is an outline of this segment of the talk. We're going to first talk about a little bit about a background about the landscape of our center. Then I'll talk about our program itself. Again, referral pathways, and then some of the patient selection protocols. So landscape, who are we? So MedStar Washington Hospital Center belongs to a large network of hospitals that span the DC and Maryland regions. And I'm sure many of you come from hospital centers that are similarly sort of structured in a kind of hub and spoke model. Our main campus is located in Northwest DC in Columbia Heights. We are the safety net hospital for the District of Columbia, so we serve a very underserved population and a large Medicaid payer mix. We do about 100 advanced heart failure therapies per year. We have a large infiltrative cardiomyopathy program as well, and then we have sort of this burgeoning of the small devices and have started programs for each of those too. About 75 to 80% of our patients self-describe as African American or ethnic minority, just to give you a sense of our demographics. I like maps, so just to give you a sense of the geographic spread of our program, in the red stars that you see here are where we have inpatient and outpatient presence, so both in Washington, D.C. and in Baltimore, and then down here in Southern Maryland, in Clinton, Maryland. And then in yellow is where we have outpatient presence primarily, and that's about to expand as we get more FTEs, that kind of outreach. We are 10 cardiologists in D.C. led by Dr. Farouk Sheikh, and 4 in Baltimore led by Dr. Samar Najjar, and then our director in Southern Maryland is Dr. Kayukis. So our Barostim program right now is small. I think small, particularly relative to the other kind of volumes that we see in the rest of kind of the therapies that we offer at our center. We just launched in January of 2023. We have actually 25 recipients so far, and then an additional 8 that are kind of waiting in the pipeline, getting worked up. Where do our referrals come from? I think it's kind of interesting to also look at this on a map because, a big proportion right now are coming from the main hub in DC, but we're having an increasing number of referrals come out from private practice community cardiologists that are out in the community and referring to us. Places that are really, this whole radius is probably a 3-hour drive if you look at everything that's in the map here. The referrals, as I mentioned, roughly 40% are coming from non-MedStar affiliated practices, which I think it's really interesting to look at these referral patterns. Also, interestingly, about half of our referrals are actually coming from non-advanced heart failure cardiologists, which I think is just an important point to make, that it's general EP interventional cardiologists that are also sending these patients to us for evaluation and to determine if the therapy is appropriate. And then roughly a quarter will come in through direct-to-consumer advertising where patients are reaching out through the website or social media, expressing interest in being evaluated for the device. So referral pathway, kind of how have we kind of achieved these referrals? A couple of months ago, we created this mailer, which basically kind of went out to all DMV area practices, both MedStar and non-MedStar cardiology practices. And this mailer basically, reviews the clinical indications for the device, gives a little description of what it is, how it's implanted, and who are the patients that we think about implanting it in. And at the very bottom, we have a phone number and an email, and this is how clinicians in the community can send in referrals to our centers. So it's as easy as just sending an email. We get, by we, I mean myself, some of my heart failure partners, and then our implanting vascular surgeon gets all of those referrals. I want to preface this slide just by saying that it's really important, I think, whenever you're introducing a new device or therapy and building a program, that stewardship of that therapy is really important. And so to that end, we kind of have an algorithm for how we review every patient to make sure that we're selecting the right therapy for the right patient. It may not always be Barostim that's the right therapy for that patient. We sort of take a bird's eye view and evaluate the patient fully to see what they need. So So what we do is first offer a review of records and directly communicate with the primary cardiologist that's referring to determine if Barostim or something else is appropriate for the patient. We also offer, as long as the primary cardiologist is okay with partnering with us, an appointment with a heart failure specialist, either telehealth or in person, and to help with heart failure staging. If after this review it's felt appropriate to proceed, meaning heart failure has reviewed the patient, primary cardiology agrees, and most importantly, we've completed shared decision-making with the patient, then we go ahead and move forward with the requisite testing for insurance authorization with the carotid ultrasound, NT-proBNP, and then schedule, finally, the visit with the implanting surgeon. So how do we select the right patient for a therapy like Barostim? And this is just kind of the messaging that I give to kind of the community cardiologists that are in our region. I like the phrase of sort of considering the patients for the therapy that are too sick but too well. So too sick, meaning that these patients have heart failure with reduced ejection fraction, but are still symptomatic despite guideline-directed medical therapy and despite CRT, or have had recurrent heart failure hospitalizations despite these guideline-directed therapies. But too well, meaning that they're not sick enough to the point that their prognosis overall is poor, and they would benefit more so from something like LVAD or transplant, so not the stage D population. These are kind of our general guidelines for patient selection at our center. We don't consider Barostim if the patient is indicated for another guideline-directed device, then that's what should be done first. So CRT, for instance. If the patient has amyloid, autonomic dysfunction, or bradyarrhythmia, that's specific to our center just because of the theoretical risk, or theoretical impact, rather, of just increased parasympathetic activation. Like I just mentioned, if the patient is stage C with life expectancy less than a year and will benefit instead from an advanced therapies evaluation. And if there's clear alternate non-cardiac explanation for the exercise intolerance, then the answer is, of course, to treat those comorbidities first before considering a device like Barostim. We're all familiar with this figure, I think, particularly if you're a heart failure cardiologist, that there is a golden window of referral where it's the right time basically to refer patients for advanced heart failure therapies. We use this clever mnemonic, the I need help mnemonic, to kind of assess this. I would argue that there's a similar kind of golden window of referral for device therapy, and that is earlier than at this point when patients need advanced therapies, but after that time that you're initiating GDMT. And so between the time that GDMT is initiated and by the time that a patient needs something advanced like that or transplant and has progressed to stage D, there's this huge window of opportunity where device therapy can play a really important role in delaying the progression of heart failure to more advanced stages. To that end, that sort of forms the basis of our algorithm at MedStar kind of for heart failure staging and kind of how we choose patients who might benefit from Barostim. So if we have a patient with an EF less than 35% who's been optimized on GDMT, they've gotten CRT if indicated, or are still symptomatic despite CRT and have continued impaired quality of life, then we will try to risk stratify that patient a little bit better, explore a little bit more why that patient has impaired quality of life by the form of some objective testing where we can. So CPET testing, right heart cath, NT-proBNP, just for instance. If based on this risk stratification that we think the patient is low to moderate risk, then we will offer Barostim to those patients. If we think they exhibit high risk features that would limit prognosis, then we refer for advanced heart failure therapies. Just a couple of important anecdotal observations I wanted to throw out there. We find that there are better patient-reported outcomes for those patients that are referred earlier rather than those patients who are later and sicker. This is not a bailout for cardiogenic shock or for inotrope dependence. We tend to find that blood pressure also remains the same after implant and throughout titration, and that we can sometimes increase the better tolerance of GDMT afterward. And there may be augmentation of diuresis, so you may need to adjust diuretic. This is an example of just sort of what we use for titration. We try to titrate the device over 2 to 3 months and do titrations every 2 to 4 weeks, just depending on the patient. At every titration, we try to have a clinician, either APP, MD, or RN, check in with the patient to determine if their medications need to be adjusted, whether a diuretic needs to be changed, or whether neurohormonal blockade can be increased. We do have some center-specific protocols. I won't spend a lot of time talking about this here. Right now, we're the only implanting center in DC, but the titrations, which patients love this, is that they can be done at other, local cardiologist's office. We like to be able to track response also after maximum titration with objective measures where we can, where it's logistically feasible, and also as part of standard of care for heart failure staging for these patients. And then we have some situations I've listed here where we will inactivate the device. So to summarize, of our patients' experience, of our program's experience thus far, roughly 90% of our patients have reported subjective clinical improvement, which is on par about with what was found in the BeAT-HF trial. The ones that really didn't have improvement or didn't feel better after the device went in are really those ones that I think were sicker and more toward the stage D spectrum of disease. Thanks so much.
Thank you. Actually, stay there. We're going to ask a couple questions. We're going to tackle 2 questions. Actually, I'll start off. So one concern or possible concern that comes up is, will this actually change the volume of LVAD and transplants referrals that you get, because you might get them out of the pipeline, because that might be a concern to a large and busy transplant program like yours.
Yeah.
What's your experience?
That has not been the case at all. If anything, I think we're getting more referrals for those therapies because we're just getting patients from the community that we wouldn't have gotten otherwise, who wouldn't have ever otherwise been reviewed by a heart failure cardiologist. And so I think that's actually a really important question and an important point to make, is that hasn't been our experience.
Yeah, I think it's a great point that you made about the earlier window of opportunity for the devices where you can meet those VADs way before then. But you mentioned a subjective improvement in 90% of the cases. Do you track any of the objective metrics in your cohort?
Yeah, we try to. I have sort of a protocol for how we track just symptoms objectively: right heart cath, CPET, NT-proBNP. In practice, it's less easy to do this if patients don't want to get those tests done. But wherever we have the data, we're tracking it.
And then Raj, a question for you is, so how do you actually introduce the concept to your patients? I mean, you showed this fancy 20 slides that you probably, can pitch it to the clinicians, but what's the patient?
I mean, my pitch to the patient is similar to what I described earlier, where we talk about the drugs as our sort of pillars or cornerstones for therapy. And in those patients that remain symptomatic, it's really just kind of explaining in a lay term how the device works and the fact that we are targeting that cascade upstream. I think patients really respond to that discussion about the fight or flight response and this sort of chronic activation being sort of adrenaline overdrive, and talking about why each of those drugs are important. What I describe it as those drugs provide a shield around the heart, essentially, to kind of protect the heart from this kind of constant barrage of signaling. But what the device does is reduce the amount of signaling in the first place, so that shield can be more effective. And that's been...
Pat, you had a comment?
Yeah, so I think we take a little bit of a different approach in that anybody that comes in and sees us, we discuss meds, devices, and advanced therapies with them, because heart failure is progressive, right? And people have inabilities to tolerate therapies in terms of medicines for a particular reason, or maybe that changes as they progress on their trajectory. And so it just gives people an awareness that there are a lot of tools that we have, and depending on where they are in their journey, we might need something a little different. And I think it sets the expectation that we're going to try and do the best we can with medicines, but we also have some devices that hopefully can delay, maybe indefinitely, or at least for a period of time before people need advanced therapies, understanding the challenges that come along with those.
And so in your experience, what about the pipeline to LVAD and transplant? Does it change it, accelerate?
No, I think we increased our VADs by like 15% last year, and we do a bunch of Barostim every year. I mean, done over 100 now. So.
Okay.
Richard, what about this? You mentioned about DTC referrals, where they usually come from, and what do you do with those? Any comments on those?
Yeah, so those, usually we get sort of, they fill out a form for us that tells us a lot about themselves, the patients, what GDMT they're on, who their cardiologist is in the community, which is helpful for me because then I can connect to that cardiologist. And then just a little bit about how they're feeling. Then we sort of just reach out to that patient and set up an appointment. I'll reach out to the primary cardiologist who kind of owns them, just to close the loop.
They usually come from cardiology, or you get some that come from primary care?
It's generally been cardiology.